Hi, my name is Drew Giardina, coming again with Total Sports Therapy's Community Spotlight. We had previously talked with Dr. Shane Martin on his specialty within orthopedics, and we're coming back now, going a little bit more specific on what his specialty is, looking more at total knee replacements. And we did a Q&A with our newsletter to people who have signed up with our email blast, and we have a few questions that we've gotten submitted from patients that we'll be asking, as well as some generalized questions regarding anything you may want to know regarding total knee replacements, when to get them, how it kind of goes after the surgery, those kinds of things. And Dr. Shane Martin, specialist in the area, is going to be helping us with those types of answers. So welcome again, thank you.
Yeah, thanks, Drew.
So we'll just get kind of right started. We do have some questions we're going to get into at the end that were submitted directly from patients through the email newsletter. So we'll get into those later, but we'll just kind of dive right in from the start and just kind of tell us a little bit about what a total knee replacement is from the standpoint of, when the patient comes to see you till having surgery.
Right. So total knee replacement is a surgery that patients that have painful knees sometimes need to stay active. The most common reason for patients needing a knee replacement would be arthritis, osteoarthritis, by far the most common reason. There are some other reasons, post-traumatic arthritis, psoriatic arthritis, or other issues with the joint where a patient is not able to function because of pain or deformity. A knee replacement can restore that function to a patient's knee.
Okay, so going along with that note, one of the questions I get quite frequently in physical therapy, if they haven't gotten to the point where they've gone to see a specialist like Dr. Martin, is, what are the signs and symptoms, kind of the things I should be looking for when the time is to go see a surgeon to discuss the possibility of having a knee surgery, not necessarily meaning that it's going to necessarily be needed immediately. What are those kinds of symptoms they should be looking for?
Yeah, pain and swelling, the most common symptoms that a patient would have that kind of drives them to see a physician. There are other things like instability that usually comes after an injury of some sort where a patient's knee is unstable. But patients that are having pain, swelling, they're not able to maybe walk as far as they normally walk or exercise the way they normally exercise, would typically go see a doctor to have their knee checked out.
Okay. And on that note, I know a lot of patients, real quickly, they have an apprehension of seeing surgeons, and I know you've probably heard it, and I hear it a lot, and I try to dissuade it quite a bit.
It's because we're all mean.
Yeah, well, that, and that they say, they're a surgeon for a reason. They make money on surgeries.
Yeah.
That just is the furthest thing from the truth, with the quality surgeons that are out there, and especially with Dr. Martin, is you're going to get, honest answers. It doesn't do anybody's business any good to be operating on people that don't need the surgery done. So, that going on that topic is there's always conservative approaches, and maybe I'll just touch right into that. Is like, let's say a patient comes to you, and we'll get into into what it means when they need to have that surgery. But let's say a patient comes to you, and based on an X-ray that you've done and the history and signs and symptoms, they're not necessarily a candidate for therapy. How do you approach that patient?
Yeah, so there are a lot of treatments available for arthritis. Now, none of them are curative, right? So the only treatment that will cure the underlying problem, which is the arthritis, is a surgery, but that is always the last resort. And you would never recommend surgery on a patient who hasn't exhausted conservative treatment. And so just to kind of go through the conservative treatments, frontline therapy would be an anti-inflammatory or Tylenol to manage the pain. After that, sometimes bracing is helpful depending on the underlying pathology. Injections like cortisone or hyaluronic acid can also keep the symptoms at bay for years before a patient needs surgery. Physical therapy is key to stabilize the joint. You can probably talk a little bit more about that. But all of these treatments can allow a patient to be functional and do the things that they want to do, avoiding surgery or putting it off for years.
Okay. Just real quick, a lot of people probably know what cortisone is, but just briefly, you said the hyaluronic acid. What is that specifically, and what is the purpose of that?
So it's a gel. It's a thick gel substance. Hyaluronic acid is something that's naturally produced by our knees, by the synovium or the synovial lining of our knees. But as we age and we get arthritis, our knees produce less and less of it. So we're actually supplementing something that's already there, and it provides a cushioning effect, some anti-inflammatory effects as well.
Okay.
But it can provide relief for up to 6 months.
Okay. Yeah, so kind of piggybacking on that, when you brought up the physical therapy, there are times when, a lot of times people who have been dealing with knee pain for long periods of time, their gait starts to get altered, which is a huge factor in a lot of pain signals throughout the body. Talking about the instability, maybe somebody was a high school athlete or an athlete in their 20s and damaged a ligament and never really went through the therapy at that age to try to help stabilize the joint. Physical therapy, the point of it to try to prevent surgery is to work on stabilizing the knee from a strength and balance standpoint, normalizing any gait abnormalities they may have that could be contributing to altered mechanics in the joint, and is a lot of times a big reason for having pain in the knee too. So therapy is definitely something that can be an option if surgery is not necessarily there yet. So going right into it, Dr. Martin's brought a couple of knee models here. We'll just kind of dive right into those. What do you have for us here?
Yeah, so when you've exhausted conservative treatment, there are two surgeries that can sometimes provide a cure for you. One is the total knee replacement, which everyone has probably already heard of. That's where the ends of both the femur and the tibia are resurfaced with metal and plastic. There's a metal cap that fits on the end of the femur, and then a tray that fits on top of the tibia with a piece of plastic in between. There's also a plastic button that gets fixed underneath the kneecap. You're not seeing that on this model, but that's a kind of a conventional total knee replacement. And then there are some other options. We call these partial knee replacements, where just portions of the joint can get resurfaced. This would be underneath the kneecap. This would be a medial or lateral compartment. And so we can selectively replace compartments in the knee that become arthritic. There are 3 compartments in every knee, and any one or all of those compartments can be arthritic at any given time. And so we have some options on the surgery side.
Okay, so we have a patient that has come to see you. They make that decision. You guys collectively make a decision. You're going to move forward with surgery. Kind of run us through that decision process. What are the next steps once you guys have decided, okay, this is what we want to do and we want to move forward with a surgery?
Yeah, so once it's decided to have surgery, then a patient is scheduled for the procedure. There are things that have to happen along the way for that procedure to be performed. For instance, the procedure has to be authorized by the insurance company. I perform all of my surgeries with a robot, and so I obtain a CT scan of the patient's knee. That's how the robot works.
Okay.
And then we prepare the patient for the actual procedure, sometimes getting them therapy ahead of the procedure to strengthen the muscles around the knee. That's where you come in.
Mm-hmm.
And that helps speed up their recovery after the surgery.
Yeah. So quickly, you had mentioned the robot. That's just a technique that you happen to use yourself as far as a way to do the total knee. There's other options, obviously. I mean, there's other techniques, obviously, but you use the robotics for that.
Yeah, that's right. So the robot became available in 2009 for knee surgery, and I've been using it since then to perform all of my knee surgeries. And it aids in placement of the implants. It provides a more accurate and consistent way to put the implants in, which increases a patient's recovery and gets them out of the hospital. About 90% of the knee replacements I do now are outpatient, where patients walk out about an hour after the surgery.
Okay.
And go home. And the robots allowed us to do that.
Yeah. I mean, I can attest to the benefit of the robotics with the replacements. I know some patients may have probably had friends that have had total knee replacements and some other replacements. What do you typically, and when some doctors do, some don't. Do you typically order therapy for the patient in their house before going to see somebody like myself, an outpatient, or do you try to get them right into outpatient if medically stable enough?
After the surgery?
After surgery.
Right, so since I'm not keeping any patients in the hospital anymore, home therapy is generally not an option for them.
Oh, okay.
And so what I will typically do is have the patient do some exercises at home, allow the soft tissues to calm down and start to heal a bit before I send them to you. So they usually see you about a week or so after the surgery, and that's when they start their more aggressive physical therapy.
Gotcha. And then early in the therapy, and I'll talk a little bit more after this question about what we see in the therapy, but what kind of recovery would you say a patient can expect in those first 2 weeks, as far as pain and swelling they should expect, kind of thing?
Yeah, great question. So it really depends whether you've had a partial or a total. So partial knee replacements, it's less surgery. You would expect to recover faster, and you do. Most patients would say about 2 weeks after the surgery they feel about 80% recovered. So for the partial knee patient, they would walk out and go home about an hour after the surgery. They typically would have about 2 days of pain and discomfort in their knee where they might need some pain medicine. And then after that, they're maybe taking a Tylenol or Motrin. But they're functional the whole time. They're up walking the whole time. They can start exercising a week or two after the surgery. A total knee replacement is more involved, obviously. It's more surgery. Those patients can still go home right after the procedure, but their recovery is a little bit longer. Almost all of those patients do about 4 weeks of physical therapy just to get their strength and range of motion back and to get them back to activities faster.
Yeah, and that's kind of what we, when the patients get to us after surgery, our first immediate concern in therapy is we're one of the first people to see this joint. So we're initially looking to see if everything looks good from an infection standpoint, and then the immediate goal in therapy is range of motion. Working on trying to get the flexion and the knee straightening as well, and then at Total Sports Therapy, I really focus on gait. Getting the gait normalized contributes to movement in a correct way, preventing other issues like hip and low back pain from compensating due to the gait patterns. But then you get that knee pumping and moving correctly in a gait pattern, then a lot of that swelling kind of just takes care of itself.
Yeah.
It doesn't puddle down in the foot and the ankle.
Absolutely. I tell all my patients that a stationary bike is the best exercise that they could get after knee replacement.
Yeah.
At the right time.
Yeah, yeah. And he had mentioned also, Dr. Martin, sometimes therapy before surgery is appropriate, and the goal of that, some people might, because I've been asked this question, what is the point when I know I have to have surgery? My answer to that is exactly what you said. The better you can be, whether it be from a physical condition, a range of motion, a strength and balance going into that procedure, the faster the recovery times are. It's not a waste of time to do therapy beforehand when it's appropriate, because you'll see the benefits on the back end. Is what I've found. So, okay, well, I think we are gonna. Oh, I know what. One question is, after that procedure, is there anything in the immediate first couple weeks that a patient should avoid?
So generally with knee replacements, there are no restrictions. Everything is you're guided by pain, right? So if you're overactive, you're doing too much, you will have some pain and swelling in the knee, and that's your signal to back off a little bit. After everything is healed, the only thing that I recommend that patients don't do is become a runner. And there's not a lot of data supporting that, but we believe that the impact will tend to wear down the plastic piece in the knee replacement prematurely, and so we worry about that.
Okay. What are the time frames they're saying? I know people hear different things as far as average time frames for having a knee replacement and having to have another one, if ever.
Well, so we tell most of our patients to expect 15 to 20 years out of their knee with normal use. Obviously, the more you use it, the faster it's going to wear out, and that's just based on laboratory data. But that's a pretty good rule of thumb.
Okay. So we sent out the Q&A newsletter asking patients if anybody had any specific questions. And I'm going to go ahead and move into a couple
Sure.
of questions that some patients submitted. First off, thank you for anybody that took the time to look into that and submit a question. We appreciate it. And we'll get into, I'll briefly touch on that again at the end when we're done as far as moving forward, if you'd like to become part of the newsletters as well. So one of the questions we got that came in, patient had a replacement in March of 2020, feels good. Previous to that had a replacement in 2017 and has some discomfort with that knee day to day. This patient was just curious, can you get arthritis around the components of the knee replacement?
Yeah, good question. So the answer is no, you can't. So arthritis refers to the process of the cartilage on the ends of the bones wearing away. So a knee replacement, especially a total knee replacement, replaces all of any existing cartilage with metal and plastic. So there's no possibility of developing osteoarthritis after a knee replacement. Now, there are other forms of arthritis. Rheumatoid arthritis is not a problem with the cartilage itself. It's more of a problem with the synovium, the lining of the joint. And so if you're a rheumatoid patient, you could potentially have pain and swelling after a knee replacement. But the majority of knee replacements are done for osteoarthritis, and there's no chance of arthritis occurring again after that surgery. With the partial, it's a little bit different, right? So with the partial, you're replacing just one or two compartments at a time. So there is a compartment of the knee with cartilage still left in it. That could become arthritic over time, and then there could be a need for additional surgery down the road.
Okay. And then we had another one. Patient wrote in, said he had she had a torn meniscus and bone on bone in the left knee last summer. Went up a ladder and tore the ACL. Has been wearing a brace, walking with a cane for stability. 75 years old. Is that possibly somebody? Should he consider a knee replacement?
Yeah. So if the question is, am I too old for a knee replacement? The answer is no. Age, chronologic age, is not an indicator or a contraindication to having surgery. The health status of a patient, their comorbidities, those would all kind of play into whether or not they should have a knee replacement. But it's definitely something you'd want to discuss with your surgeon. But age by itself is not a reason not to have a knee replacement.
Yeah, I totally agree with that as well, especially with the way talking about doing some of these procedures outpatient, the time frames in which the patients get themselves back into a rehab situation back home. It's the whole process has been sped up in terms of recovery times, just due to the way the procedures are done and how quickly they get people up and moving. It's compared to 15, 20 years ago, even 10 years ago, really, for that matter. So I've got a kind of a question or kind of a statement. I had a patient recently who had an accident that created a lot of instability in the knee, and to the point where had some ligament damage to the, this patient had some previous arthritis that wasn't a problem, but due to the injury, tearing of some ligaments, became very unstable in the knee. Ligamentous repair wasn't an option, but she was continuing to have a lot of problems due to that instability. Is that somebody that, with the components that you use for the total knee, that could benefit from having a replacement?
Yeah, so ligament issues can sometimes be corrected with a knee replacement. Stability issues can almost always be corrected with a knee replacement, and that's because of the components that we use, the way they're designed. You can see here that there is a concavity to the implant, or a kind of a dished look to the implant, and that fits kind of together with this rounded condyle. And so that offers a lot of front and back stability, which takes the place of the ACL. So, that ligament's not needed after a total knee replacement. We have to take it out, actually, to do the procedure. And the implants themselves then give the knee stability.
Okay.
And that's really where doing it robotically helps a lot, because it helps us to balance the ligaments that are remaining in the knee, put the implants in the right position so that the knee feels balanced and it's not loose on one side and tight on the other.
Good.
That's something that's very difficult to do without a robotic system.
Okay. So, thanks for watching again. This is another series and part of the Community Spotlight. Like I said, this was a specific Q&A that we sent out a newsletter to anybody that has registered their email address with us to give you the opportunity to submit your questions. If you look below, we'll be putting information there for you to register if you'd like to become part of our newsletter, and potentially look out for some of these postings that we have for this type of situation where we have a physician and a Q&A, and might be with Dr. Martin again. And just like I said, there'll be something there to learn how to register your email, and then just be looking out for the newsletter when we send it, and there'll be something on the newsletter showing you how to submit your question. So appreciate the time Dr. Martin gave us again today. He's been gracious with coming here again, and look forward for our next video on our YouTube series.